Hey everybody, Dr. Natalie Gentile back with another amazing Rebels in Wellness interview. This series is built on interviewing people in their respective industries who are rebels and who are pushing the limits to do better for humans. So I'm so excited to have Dr. Maggie Landes here today. I've been watching what she's doing on Instagram for a long time. And as we uncover more about anti-diet culture and healthcare bias, especially due to one size, this stuff, as you'll hear from her, she said she can't unsee it. It's so true. So I'm so excited for us to all learn together. And thank you for being here today, Dr. Landes.
Well, thank you for inviting me. I'm happy to share this message with, more people. It's just something that I don't think we as professionals talk about enough. So
can you tell us about your background?
Sure. Well, I'm actually a board certified pediatrician by training. That's my medical background. And I will be the first to admit, so I'm in my mid 40s now. I grew up in the 80s and 90s, product of diet culture, product of, this sort of whole belief system that, your size is a major driving factor as to whether you're going to end up healthy or not healthy, And then I went to medical school and that belief system was basically reinforced, you know that, right? So I spent the first 15 years of my career, like treating patients the way that I no longer believe is the most evidence-based ethical way to treat patients. And I've learned, and I've probably harmed people by things I said, but I know better now and I'm trying to do better now. The interesting part of my story is I actually started learning about this after I myself became a patient, a cancer patient, like of a serious, condition. And I started really reading about, long-term nutrition studies and that sort of stuff, like articles, not Instagram. Okay.
Yeah.
And I just didn't find like the sufficient data to support what I had been taught to tell patients. Right. And so I decided, because I'm one of these people that just like, is like goes all in. I was like, I'm going to go back to graduate school because maybe I'm the problem. Maybe like enough time has gone by that like I have kind of antiquated training and like I need to go back and see what they're teaching, nutrition professionals and that sort of stuff in the year 2018. So I go back and spoiler alert, it's the same thing. The same thing, like no kidding, food pyramid and all the same nonsense. And I'm like, oh no, this is a problem because this is not only a big cultural narrative that is really, in my opinion, not supported by science. We are still 20 years later teaching health professionals. And if the health professionals don't have like really a solid ground to stand on in terms of continuing to prescribe weight loss for everybody that walks in the door, how are we going to get out of this conversation? I mean, that the average non-health professional person is not going to know the answers. So, once you see the sort of harms done, and it's so deep. I mean, we can get into this a little bit, but it's not just, oh, we need to be nicer to people in large bodies because we don't want to hurt their feelings. It's not anything like that. It's like, it's a social injustice that they don't get dignified, ethical healthcare because of their body size. That's a problem. And I think as professionals, we need to hold ourselves to like a much higher standard. And I don't blame all the professionals. I'm not here to throw the doctors and dietitians under the bus. We were trained to prescribe these things. And frankly, I mean, you went to medical school too. Like there's so much information. If some dude with a bow tie and white hair is standing in front of the lecture hall when you're a second year medical student and tells you that obesity is killing everybody in the country, you just say, yes, sir, and keep going. You don't have the luxury of like being critical of every single piece of information. You just pick it up and move on, especially if it is like concordant with what you already kind of believe from just everything. You're like, okay, yeah, sure. God, right. Okay. And, not until and I will tell you, having this sort of forced pause when I was going through my cancer treatment and doing this kind of deep dive study is what made me deliberately decide to change my mind and change the way I talk to patients and handle healthcare. And now I've essentially shifted I don't do a lot of clinical work anymore. Now I mostly am a sort of educator, both to other professionals, but also to people and empowering them how to navigate the healthcare system when it is a biased place and a very complicated and frankly, dangerous place for people in large bodies.
There's a lot to unpack there.
That's a lot. Welcome to the
all
show.
You do? Really?
Yeah,
that's all.
That's all. Yeah. And I take Sundays off. Yeah.
So, okay, can you share some of your experience from the patient side of things that started to open your eyes?
Well, so one of the things when I started talking to women my age, and my age being, 40s, 50s, whatever, sort of like midlife people that grew up with diet culture. Okay. I could not believe how many women in their, let's say 50s they have serious body image issues, have disordered eating, maybe even have eating disorders based on a single comment they got from a pediatrician when they were a kid. They remember the day it happened when they were there for their 7-year-old physical, and the nurse weighed them and made some joke about like, oh, somebody's been having dessert every night, or so, just something super like small in terms of like a contact point. Yeah. But they believed in that moment that their body is not acceptable, that they have to change their body to be accepted, to be healthy, to be loved, to be worthy. And they have carried those belief systems for half a century forward. And I mean, when I hear stories like that over and over and over, man, every single touch point matters. These are very sensitive issues, and it's little tiny things can have this like downstream impact that's unbelievable. I mean, I shared with you before we started recording, I get emails from people and messages and stuff. And the worst possible thing is when people are so stigmatized, they leave the healthcare system altogether. They have an experience that is so bad that they just don't go back. Not only do they not go back to that provider, they don't go back to anybody because they're like, forget it. And then they go years, decades, even without any care. I mean, and that's like the worst possible setup for something bad to happen. But then we have this thing, it's sort of this self-perpetuating thing, because what happens, then they eventually show back up. Okay. So let's say a 25-year-old woman comes in for a sinus infection and the doctor gives her antibiotics, and referral to bariatric surgery because, she's obese or whatever. And that impacts how she interacts with healthcare forever. Doesn't go back. Then she pops up, she's 50 and she's got like a metastatic breast cancer because she's never had a mammogram. She's never had a doctor's visit, and then we collectively publish all these papers that say, well, look, all the fat people got breast cancer. So we need to tell the fat people when they're 25 to not be fat because then they're going to get breast cancer. And you're like, wait a second. Like weight stigma and this kind of interaction in healthcare is not quantifiable. It's a what we call confounding variable. I mean, I'm saying this for your audience. I know you know what that is, but a confounder that you can't control for in research and in health studies and nutrition data. And so it's there and it's affecting these things. And when there's correlations, because basically what has been shown is that yes, there is a correlative relationship between being in a large body, developing heart failure, developing diabetes, developing whatever, all these things. But there's not controlled information to say that it causes, like fat on your body makes you have diabetes. Well, that we know that's not true, because otherwise every single person with fat on their body would have diabetes and nobody with a slender body would have diabetes. That's not how it works. Right. So there's certainly more things at play. One of which the major contributors is the fact that people in large bodies, get less quality healthcare, less quantity of healthcare, and they deal with the stress of weight stigma, both in the healthcare system and in our society at large, which increases your cortisol response and your blood pressure and your all these things. And when you have those things interacting at play, then it's not actually shocking that they would have worse outcomes, but the outcomes are not as a result of literally, we can't at least prove that they are a result of tissue on the body, because we don't have any way to control for all these other things. And I don't like people feeling like they are inadequate participants in their own healthcare. Like everybody should get an opportunity, if they choose, to interact with the healthcare system and participate in the pursuit of health, however that looks to them, which will be very different based on their goals, their belief system, their socioeconomic status, their age. There's so many things at play. Like I really think the best providers are the ones that kind of like loop everything back to the patient. Like I'm not opposed to really like any specific recommendation aside from just uniform weight loss across the board. I am opposed to that, but everything else, like, is this going to work for you? How do you envision if I recommend that you get a little more physical activity, like what would that look like to you? Like, what do you think is like the minimum plausible amount that like you could see yourself doing, and asking instead of telling. It's like, well, you got to work out for 30 minutes, 5 days a week and get your heart rate over 120. Well, that may be what you do or what I do or what a specific person may do, but it's just like speaking a foreign language to some people. And then the answer is that they think in or out. Like, if I can't do that, I can't do anything.
Yeah.
So like, what's the simplest thing? The simplest thing is you're going to go outside and pull weeds in your garden bed for 10 minutes a day and do a like up and down a couple times, Okay, that might be it. That might be a success story. And not only is any physical activity, it's like gives them a little feeling of like, okay, I gotta win. I gotta win, and not only can I do something to work towards health, my provider, like we have a good relationship. They believe in me. They're going to give me actionable things that I can, within my resources to do. And then it keeps getting better from there. You can add on stuff, and we just aren't trained to do that. I mean, by and large, doctors don't have training in that kind of stuff. I don't know about you, but I don't even think the word social determinants of health was like in my medical school curriculum anywhere, like not even a byline. And it's a major factor. I think the best providers recognize that and can incorporate that into their assessment and their treatment plans.
So I mean, going through my training and just with my personal interests in fitness in particular and nutrition, I totally had that mentality in the back of my head that it was like, but we should, regardless, whatever we're seeing in a primary care setting, most of it can be fixed if you lose weight. Like that in my head, that's kind of how I was trained and how I thought and what I saw in the magazines and what, that was kind of what was ingrained. And it wasn't until I saw some patients come in who had larger bodies and they had high blood pressure. And if they lost weight, their blood pressures got better. And some of them didn't. And some people who were in smaller bodies who had diabetes and it didn't, like everybody was different. And weight loss wasn't the solution for every person. And you can have a bigger body and still be healthy. And you can have a smaller body and be unhealthy.
Right. And what the data shows is that health, see, at the end of the day, your weight directly is not an actionable item. Like you can't just sit here and like make myself smaller. And I say that because yes, I can. I lost however many pounds. And I said, well, really? How'd that work? Well, I started drinking water instead of Coke and I started walking and blah, blah, blah. I'm like, okay, now those things are like line item things, but you can't just change your weight because there is environmental factors and genetic factors and all hundreds of factors. So what the research shows is that when you take on health promoting behaviors, stress management, stop smoking, sleep hygiene, a variety of nutrition, hydration, physical activity, all those things, your health metrics will improve and it's independent of your size. So when you do those things, your health is basically guaranteed to improve from where it is. Yep. Your size is not guaranteed to change. It may get smaller. It might, in the course of doing that, it might not. And the problem is we have the narrative that if you're not getting smaller, nothing good can come of it. And so then we just stop.
Yep.
We're like missing that's not really the target. The weight loss or weight gain or weight maintenance is like a byproduct of the activity, but it's, but we're trained like exactly. I mean, that's what I said. I don't, shame doctors who really have never even heard this message because we are trained like, just like you said. And the other thing that makes it even worse is a lot of healthcare providers, doctors, dietitians, physical stuff, have had a very high level of personal interest in body, fitness, nutrition, even preceding their profession. And so that's why they chose that profession. I mean, the rate of eating disorders in dietitians or dietitians in training is like higher than the baseline for the population, the age matched population, because they believe this stuff can be controlled. And so if I can control all this for myself, I might as well go to school, get a degree, and then get paid to control it for you. Right. That's the, the thought. And so, we have an probably even more biased professional workforce than the baseline of the population, so we're kind of up against like really a behemoth of a problem. But it's not, we're not asking anybody to do anything besides understand the evidence and provide ethical, evidence-based solutions for the patients. That's really it. This is not crazy talk. I know this is like rebels and wellness, and it seems so like such a rebellious idea, but it's actually a very simplistic idea. It's just not.
But it is rebellious because it's not our norm.
Yeah, it's not. Like, it's not the dominant narrative, right? Yeah, it's not. But this is what I tell when I get doctors that kind of butt up against my belief system a little bit. I say, okay, I'm gonna play devil's advocate for a second. Let's say that there is a health benefit to losing weight. Okay, I don't believe that's true, but let's just say that's what they believe. Let's say, if that's the case, we have been telling patients to lose weight for probably 50 to 60 years now, and our patients are larger than they were. So even if the goal is to make them smaller, what you're doing right now is actually not even achieving that goal. And lay aside the secondary goal that like it actually has no correlation with health, but like what you think you're doing, you're not even actually doing. So maybe, and I would kind of like put the corollary on there that maybe the fact that people are getting larger is a result of us telling them to diet and lose weight. Like,
not helping it.
Yeah. Well, and it's interesting. I usually, when I'm teaching people, I show this graph that's got like and I think BMI is totally bogus, but that's what is used in a lot of this literature. And it's got the BMI, the average BMI of the American population starting back in like the 40s, and it like goes up every decade. And there's like this very, very gentle increase slope over from the 40s till, whatever. And then right between 1975 and 1980, there's this like abrupt takeoff. Well, guess what that is? So the first, I mean, this, but the first, edition of the nutrition guidelines for Americans were put out in 1977. And that's the first time that the US government has basically told people this is the best way to eat and every American should eat like this. That's the first time they really were like united in that. I mean, there were like people saying this and doctors saying this, but this was like, everybody needs to do this. This is how we should feed school children in the military, and this should be served in hospitals, and that's when this huge rate of size increase in our population occurred. It looks like it almost started like that year. And of course, that's not a proven, controlled study either, but I just feel like there's got to be part of the problem is us telling everybody that their size is a problem. That like is the problem. Right. And all we're just asking is to like not tell people to manipulate their size. Like, well, how am I supposed to treat hypertension? I was like, really? Well, is that the only thing you know, how to treat hypertension? Like any reasonable doctor could make a list of like 20 things that would potentially help hypertension. So write all those on a list. And then the number one where it says weight loss, just put a line through it. And then you can still teach the other 19 things. Okay. Because all that is valid. Where it's really just and the thing is that it would go so far to not only, in my opinion, improving people's health, to keeping them engaged and trusting of the healthcare system. And doctors have a lot of experience to offer. We are specialists. We've been trained for decades. And I don't want the patients to completely discredit all of that just because you're sort of naive to, we have to have this relationship in the exam room where we are the experts in our discipline, and those people, the patients, are the experts in their lived experience.
Yep.
And if we both can share information from our perspectives, and then we're not telling them what their life looks like or how they should live, and they're not telling us what drug we need to prescribe them, like it could work if we both kind of respect that experience. But it so often doesn't it doesn't feel like that, to people in larger bodies. And I mean, I'm in what's considered sort of a, I guess, small fat body. I don't know, I'm not in an extremely marginalized size, but I'm in a plus size, right? And I am a doctor who does this work, and I go to the doctor for a doctor that I've seen for quite a while, and he'll make a comment about something that's like unrelated, totally you're in there for something totally unrelated, and then it's like, well, you should probably eat lower fat diet. I'm like, really? Because what year is it? Like 1984? Are we still talking about this in here?
Yeah.
And I know what that feels like to me. I mean, fortunately, I've kind of I'm like, okay, gotcha. But it does sting a little bit. And I'm the one who's the most knowledgeable about like kind of brushing this stuff off. Every other person they're sitting in the parking lot of the clinic crying in their car on the way home. And like the stories I hear are just trauma. I mean, it is a traumatic experience. And it's just, I think that's the worst possible thing. And I don't think most of the providers recognize that that's what's happening when they walk out of the doors. Because most of the patients, I mean, some of them will confront the doctor, but a lot of them just kind of like hold it together for this appointment, get what they came for, and get the heck out.
Right.
And so it's kind of like underappreciated, but I think we'd have, more compliance with the things that we want them to comply with if we're not so like ignorant of the setting in which we're delivering our healthcare.
There's also a lot of shaming, I think, in both directions. So there's the shame that, can be put on a patient. You need to lose weight. It's your fault. You failed that diet, like that kind of shaming. But on the opposite end of the spectrum, if a patient is coming in and they're, for example, coming to talk to me because they want to lose weight, their body doesn't feel good. It's hard for them to get up and down and pick up their grandkids. Their joints ache. I don't know. They're preparing for surgery and they're worried about visceral fat and the potential for it being a challenging surgery or complicated post-op, whatever. That can't be shamed either. And what the next step then as a physician or someone in the healthcare industry is to unpack that. Well, why? Do you want to lose weight because you think you need to look like this picture, on a paper, in a magazine, or because someone told you it was bad? Or is it because of these functional things, or because you are kind of battling through some disordered behaviors? And that's where we're missing out hard, is the unpacking of the reasons why.
Oh yeah. We don't even stop to ask. I mean, it is amazing the shallow level of screening for like sort of diet behavior, eating disorders, disordered eating. It's almost not done. I mean, unless the patient brings it up as their chief complaint, it is almost, I have never had anybody ask me. Like I've had doctors tell me to do stuff about what I eat, and they didn't even ask what I was doing. They have no idea what I'm doing. Wow. Like, I mean, and I have a daughter. This is an important story, but she's in high school. She does competitive dance. Okay. So this is a 14-year-old girl, does competitive dance, like, hello, red flag, eating disorder screening. Right. And I take her in for her sports physical for dance for her to participate, to a pediatrician. 0 questions about her eating. 0. They didn't ask if she ever diets, if she feels like she needs to gain weight, lose weight, is happy with her weight, if she skips meals, fortunately, I figured this out myself, but like, hello, if the most red flaggiest of red flag patient is in the office and we don't even screen them, I'm sure we're not screening an overweight 50-year-old woman who could have an eating disorder. We have to just ask. We don't assume, we don't make a lot of other assumptions about healthcare. I mean, we ask about other things, have you had surgery before? Like, do you take medications? Have you had a pregnancy? We don't just like look at them and say, well, you look like you probably haven't had surgery. Like, I mean, come on, like that's crazy. So like, that's, to me, it sounds preposterous to say that kind of stuff, but it's like, that's almost how crazy it is. Yeah. That's almost how crazy it is. And the things that would fix this problem, or at least go a long way towards starting to fix the problem, are like low cost, low hanging fruit. Like, this is not complicated. We're not asking for, your office doesn't have to buy a bunch of technology. You don't have to like go get another training program. Like, this is just simply being informed enough to ask the most important questions, so that you get the right information, so that you can give the right information, and that you both have a productive relationship, that they continue to participate. That's really all. I mean, that's what we should aspire to do as doctors and providers anyway. And I think that's what we think we're doing, but it's really easy to kind of just get in the weeds of like how we see the world and how we would handle this problem, and how, our family would handle this problem or something. And it's just the rest of the world does not always look like what we think it looks like. And just accepting that, I hesitate using the word privilege, but it is a privilege. I mean, if you're practicing medicine or you're a healthcare professional, you have some privileged standing. Even let's just say you're fat and queer and Black and all the other things. If you have a secondary education like that, you have at least an educational privilege and probably a little bit of a financial privilege. So just recognizing like our healthcare is only as good as the context we put it in. Like, it doesn't really matter if this drug cures cancer if the patients are so mad at us they don't come back to get it, or don't come back to get diagnosed with cancer to get the treatment. Like, I mean, just, I'm just making an example, but it's no good. It's just not, it's no good. So I hope that this is not rebellious. I mean, I know it's rebellious. It sounds rebellious and sounds crazy and sounds like totally counterintuitive. And if I would have been saying this to the me from like, let's say 6 or 7 years ago, I would have thought I was crazy too. I'd be like, who is this crazy lady? But I hope in our lifetimes, you and me in our careers, we can see this problem get better. I mean, I think we can. The things like medicine changes and evolves, and our body of knowledge changes over time. And we're willing to kind of accept that with every aspect except for nutrition. Like, you don't do surgery with like 60-year-old surgical equipment. You're not prescribing the same antibiotics from like 100 years ago, but like some guy in the 1950s like said this is how we should eat. And so then like we're still like hanging on to this like it's a biblical truth. And it's like, can't we learn and change and adapt to better information? And it doesn't require shame. Like, yeah, okay, so what? You handed out the food pyramid from 1980 till 1992. Like, that's, yeah, right, exactly. I told everybody to use margarine, so don't use butter, all the crazy stuff, and that's fine, whatever. But like, okay, now we know better. We used to, there's a lot of stuff that we should be able to grow, like, and just, I don't know, evolve, I guess is a good word. And there's no shame. And we should want to do that. And that's really what providers and doctors should want to do. You're not going to learn everything you need to know in medical school and then go practice medicine for 40 years.
Right.
So let's not like hang on. Like, let's just like go to the food pyramid. Okay. Food pyramid is old news. It is over. Stop it.
Bye. Bye, food pyramid.
Bye. Oh, then they switched it to the plate. So then the pyramid became the plate. And I don't know if the plate is still a thing or they got rid of that. I don't know, but just no.
Well, I feel like we could talk forever. This is such a intense, topic, and I'm sure a lot of people are going to benefit from hearing your conversation today and the things that you've taught us. So I'm just really grateful for the work that you do. And can you tell us, I'm sure everyone knows where to find you on social media, but can you share with us where they can find more information and get in touch with you?
Sure. Well, the easiest thing is Maggie Landes, MD is my handle on Instagram, Facebook. I'm the most active on Instagram. I'm on LinkedIn there. That's my website, maggielandesmd.com. And I've got resources, and there's some free resources too for both health professionals that are interested in learning a little more and potentially sort of like, maybe I want to think about adopting a little bit more weight neutral practice. And also for anybody who is a client or patient in the healthcare system and wants some advice on how to navigate this. Maybe someday that won't be needed. If I do good enough work with the health professionals, then the other people won't need as much help. But in the meantime, I'm trying to support everybody so that we can, everybody stays in the healthcare system and we can do what we we're trained to do, what we joined this profession to do. So thank you for inviting me and letting me share some information today.
Amazing. Thanks, Dr. Landes. And thanks for joining us for Rebels in Wellness, and hope everybody enjoyed. See you next time.